over a century, medical training operated on a terrifyingly simple rule: see one, do one, teach one. Students learned opportunistically, waiting for real patients to walk through the door with the conditions they needed to study. Relying on live patients meant students often encountered complex, life-threatening emergencies for the very first time on deteriorating human beings. In 1999, the Institute of Medicine published a landmark report titled "To Err is Human." It revealed that communication breakdowns and faulty systems were causing tens of thousands of preventable, fatal medical errors every single year. The report exposed a fatal gap in medical education. Reading textbook theory simply does not prepare a student to execute a high-stakes procedure under extreme time-compressed stress. Relying on live patients for initial procedural practice became an unacceptable ethical risk. Medical education required a total structural redesign. The modern Skills and Simulation Lab provides that redesign. It establishes a strict new operational rule: see one, practice many, do one. This environment is meticulously controlled and explicitly designed for failure. Students can make critical errors and test incorrect hypotheses, but the risk to human life remains absolute zero. The simulation lab serves as the ethical bridge separating abstract academic theory from real-world clinical application. To make this training effective, the lab relies on fidelity, the precise degree of realism engineered into a scenario to trigger genuine psychological and physiological stress responses in trainees. Training starts at the baseline with low-fidelity tools. Part-task trainers like silicone suturing pads and isolated IV arms are deployed to build unconscious psychomotor muscle memory through pure repetitive isolation. Next on the spectrum are high-fidelity systems. These advanced robotic mannequins are engineered to bleed, cry, sweat, and react dynamically, even sharply dilating their pupils in response to the exact dose of medication. Because medicine requires complex human interaction, the lab also deploys an interactive layer. Standardized patients, highly trained human actors, and LLM-powered AI avatars are used to train the nuanced soft skills of clinical practice. These interactive tools allow students to master the SBAR communication framework for transferring patient data and to practice the heavy emotional weight of delivering a terminal diagnosis. Engineering this escalating spectrum of artificial reality guarantees that students experience the absolute chaos of healthcare long before the stakes become permanent. Yet, the actual learning does not happen while the student is chest-deep in a crisis, actively trying to save the mannequin. This diagram shows Kolb's experiential learning cycle. It details the psychological mechanism of how an artificial experience transforms into clinical expertise. It begins with the concrete experience. The simulation event generates raw behavioral data and emotional responses from the student. Next is reflective observation, the debrief. Facilitators guide students to unpack their clinical reasoning and share their mental models. Using frameworks like the PEARLS model, teams safely dissect mistakes, extract lessons, and forge new, corrected strategies for future encounters. The cutting-edge technology provides the immersive experience, but the structured psychological debriefing actually mints clinical expertise. This rigorous process drives competency-based medical education, the modern standard redefining how medical students graduate and advance. Historically, the standard required students to merely log a set number of hours in a hospital ward. Today, they must prove definitive, measurable competence inside the simulation lab before they are allowed to proceed. This has a direct, measurable impact on hospital safety. By demanding repeated simulation of aseptic techniques, hospitals drastically reduce the rate of healthcare-acquired infections. This training model also scales globally. Virtual reality and telesimulation are currently bringing complex surgical practice to remote, low-resource regions. The uncompromising goal of the simulation lab is the total eradication of the first-time learning curve on living human beings. The simulation lab acts as a complete redesign of healthcare safety. It ensures that when a provider steps to your bedside, they have successfully navigated that exact crisis many times before.